Please start.
So, a very good evening to one and all, and warm welcome to everyone who's joined us for this 8th edition of the Endocrine Society of India Case Capsule Series. And today we are privileged to have amongst us Dr. Kalyani Sridharan, who's an associate professor at the All India Institute of Medical Sciences in Rishikesh. And Dr. Kalyani has had an illustrious career, and I've had the privilege of working with her during a short stint while she was in Vellore. And today we are joined with her postgraduate, Dr. Jagapati Babu, who will be presenting the case. And we have other student panel members who are on the Zoom link. And I'm sure 80 plus DM students, DM and DNB students across India who joined us online. And with this brief introduction, I welcome you, Dr. Kalyani, and thank you again for accepting our invitation for taking this panel through. And after you're done with your presentation by around 8:50, I will join back to take the quiz. But over to you, Dr. Kalyani, the stage is yours.
Thank you so much, sir. Good evening, all. First, let me thank the ESI for this opportunity for this case capsule series, which is a very academic program for the DM residents. And it's very nice to be a part of this program. I have with me today my senior resident from of second year, Dr. Jagpati Babu, who will be presenting the case on acromegaly. We will take you through the case presentation and the diagnosis and the management issues that one would be generally facing. And like Dr. Nitin just said, we have a panel of 6 students here. So we have with us Dr. Payanivel from Madurai, Dr. Divyashri from Hyderabad, Dr. Shashidhar from Bangalore, Dr. Harini from Mangalore, Dr. Vishal from Bhubaneswar, Dr. Rebecca from Vellore. So welcome all students. And without much waste of time, let me move on to, I'll let Dr. Jagpati take over and start presenting the case. Jagpati, please start.
Yes, ma'am. Today I'll be presenting a 23-year-old male patient who is from Sunkari Kalan, Uttarakhand, who presented with a chief complaint of enlargement of hands and feet since 3 years and change in facial appearance since 3 years. History of present illness. Patient was apparently normal 3 years back. Patient noticed insidious onset, slowly progressive enlargements of hands and feet since 3 years. Enlargements of hands and feet was present since 3 years, and he has noticed the change in his shoe size from size 7 to size 10 of his shoes. And there was history of enlargement of nose, enlarged protruding lower jaw and chin, history of deep voice is seen, and history of widening of teeth. And he also noticed history of oily skin and increased sweating. But there was no history of any jaw malocclusion. There was no history of any enlarged tongue. History of snoring was present, but there was no history of any excessive daytime sleepiness. There was no history of any disturbed sleep. There was no history of any headache, no history of blurring of vision, no history of sudden loss of vision, no history of any joint pains, or no history of any back pain. No history of tingling over hands and feet, no history of weakness of limbs, no history of neck swelling, and no history of polyuria and polydipsia. No history of any admission for uncontrolled blood pressure. There was no history of any cold intolerance, no history of any lethargy, no history of constipation, no history of nausea, vomiting, no history of postural dizziness, no history of decreased libido. There was no history of any decreased early morning erections. There was no history of any decreased facial hair and no history of any decreased testicular volume. There was no history of any previous history of renal calculi or pathological fractures. Past history. There was no previous history of hypertension, diabetes, epilepsy, hypothyroidism, and there was no history of any previous surgeries. Personal history, patient has normal appetite, normal sleep, normal bowel and bladder habits. Treatment history, with the above complaints, patient came to AIIMS Rishikesh and all relevant investigations were done and patient underwent transsphenoidal surgery for pituitary tumor. And the patient was started on thyroxine 50 micrograms per day and prednisolone 2.5 BD. And patient came back to us after 3 months for follow-up and had persistent enlargement of hands and feet and history of increased sweating. And apart from this, patient had a history of loss of libido after the surgery and there was history of decreased early morning erections. Drug history, post-surgery, the patient was started on the tablet thyroxine 50 micrograms per day and tab prednisolone 2.5 mg PD. But later the patient stopped tab prednisolone by himself and continued tab thyroxine. Currently, patient is only taking tab thyroxine. Family history, he's the first in the birth order. It is a non-consanguineous marriage, and the family members doesn't have any similar complaints in the family. Summary of my history: a 23-year-old male patient with features of acromegaly, with no similar family history and no syndromic features, with recent pituitary surgery, with persistent symptoms of active acromegaly, with features of secondary hypogonadism and hypothyroidism on thyroxine therapy.
So, Jagpati, let me stop you here. So, in your history, you talked about the primary complaint being acral enlargement.
Yes, ma'am.
So, suppose a patient presents, especially in this age, in the second to in the second late second decade to early third decade with acral enlargement and the other complaints. What is you have written the summary as acromegaly?
Yes.
So, what would you? Why do you say acromegaly? What clinical features prompted you to say that?
Because patient had features of both acral enlargement, facial enlargement was present. There was history of increase in the sweating, oiliness of this increased oiliness of the skin, and also patient had these symptoms of acromegaly, but patient didn't had other symptoms like joint pains or headache or visual blurring. So most probably.
So, what you're saying is these physical features can be said as acromegaloid,
Yes, it can be acromegaloid,
right?
but yes.
So, what taking it from there? What are the differential for a patient with acromegaloid features?
So it can be acromegaly, ma'am, or it can be pseudoacromegaly. The causes of
Acromegaly.
pseudoacromegaly are one is due to uncontrolled type 2 diabetes mellitus, due to increase in this insulin levels, which act upon the IGF-1 receptors, causing increased acromegaloid features.
What is that phenomenon called?
Specificity is spillover phenomenon.
Right.
It can also be seen in cases of insulinoma, where IGF-1, because of increased insulin levels, there can be specificity spillover. It can also be seen in cases of IGF-2 producing tumors. It can be seen with certain drugs, ma'am, like phenytoin and minoxidil. And also it
Any
can
other
be,
cause of pseudoacromegaly? Apart, you said uncontrolled diabetes. That's a good.
yes,
Apart from
and
that,
also pachydermoperiostosis is one other differential.
pachydermoperiostosis is a
There
differential.
is,
Right.
yes, ma'am.
What is pachydermoperiostosis because of?
It is due to increase in patient have acromegaloid features. Along with that, there is clubbing is present in these patients, ma'am. Clubbing can also be seen in these patients.
Any other clinical findings which would favor PDP or what? Anything else in the history which would favor PDP? Let's involve other residents as well. Dr. Divya, do you want to add to this discussion? When would you suspect a PDP and not an acromegaly?
For other associated features like other pituitary hormone involvement or any headache, visual disturbances because of any pressure symptoms due to intracranial tumor, those points towards acromegaly. Uncontrolled diabetes, hypertension, OSA, all these comorbidities or complications also favors towards acromegaly.
Right. So, what are the points favoring pachydermoperiostosis?
Whatever I said, all these complications won't be there in that, and clubbing will be there.
Yes.
Clubbing is the main differentiating clinical feature.
Right. Anything else?
Wrist enlargement also.
What about family history? It's not because it has a genetic basis, so you would expect a family history as well in
Yes,
PDP,
yes,
right?
yes,
So that's one more pointer towards. Although you could argue that in this age group, it's not uncommon to have a family history for acro as well.
yes,
Right, syndromic association can have a familial acromegaly,
Yes.
But having said that, PDP with clubbing and a sibling with a similar complaint, we should think of PDP as a differential. Right.
Yes, ma'am.
Any other, Dr. Vishal? What are the other DDs for acromegaloid features in addition to what was discussed till now?
Ma'am, as he has mentioned, ma'am, can be due to drugs like phenytoin and minoxidil, ma'am,
Right.
and can be insulinoma, IGF-2 secreting tumors, hypothyroidism, severe uncontrolled
Hypothyroidism. Yes,
diabetes.
uncontrolled hypothyroidism. Right. That's
Yes,
again an
ma'am.
important. These are all important. Uncontrolled diabetes, uncontrolled hypothyroidism. Right. Any other pituitary tumor which can mimic acral enlargement and
And prolactinoma
aside
can
from
cause, ma'am,
GH secreting tumors.
prolactinoma
Right.
may cause acromegaloid features,
Right,
ma'am.
right. Prolactinoma or sometimes a mammosomatotropinoma. That is a tumor which is co-secreting both. Right.
Yes,
You
ma'am.
can have features of um, these. Right. Moving on to that. So anyway, so this patient had acral enlargement and features of basically an acromegaloid phenotype. Then what are the other positive findings we have here, Jagpati?
Here, we had a history of increase in enlargement of hands and feet, along with that enlargement of the nose and lower jaw, which are the acromegaloid features. Along with that, patient had deep voice, widening of teeth, and also oily skin and increased sweating.
So what is the pathophysiological basis of oily skin and increased sweating in acromegaly?
So growth hormone directly stimulates these pilosebaceous glands with the help of IGF-1 and increases the production of increases the sweating, and also seborrhea is increased in these patients.
Okay. Right. So that is basically the IGF-1 receptors activate the pilosebaceous unit.
Pilosebaceous.
Right. Move on to the next slide. You also had the patient also had some features of sleep apnea, right?
Yes, ma'am.
Patient had features of snoring.
History of
So,
snoring was present.
what about the sleep apnea and acromegaly? What types of sleep apnea do you see in acromegaly?
Yes, ma'am.
How do they present?
Acromegaly, we can see obstructive sleep apnea and central sleep apnea, ma'am. In obstructive sleep apnea, it occurs due to the increase in the pharyngeal growth and also tonsillar growth.
What is more common?
Obstructive sleep apnea is much more common than central sleep apnea. It is nearly present in 60 to 80% of the patients. And also,
Central sleep apnea because of
central sleep apnea, it is a direct effect of growth hormone on the respiratory center, which depresses it and causes central sleep apnea.
right. So, are there any features in this patient which directly talks about the pituitary tumor? Clinical features directly of a pituitary tumor. Did he have anything in the clinical history?
No, no. He
What do
doesn't.
you expect?
He didn't had any headache. He didn't had any hormonal deficiency symptoms also,
Right.
and he didn't had any other symptoms of DI symptoms also.
Would you expect DI symptoms in a pituitary tumor?
No, ma'am. If no, no.
Dr. Harini answered that. Dr. Harini, what percentage of pituitary tumor do you expect DI as a complaint? Or the corollary is this: if a patient presents with DI, say similar case, you have a 20-year-old who is presenting with features of compressive vision abnormalities, headache, and DI, what would you rather think? Dr. Harini, can you hear us?
Yes, ma'am. I would think less amount of pituitary tumors would present with DI. It's more of lymphocytic hypophysitis which could present with DI.
Right, that is a good differential. Okay, anything else? Yes, lymphocytic hypophysitis can actually mimic a pituitary tumor and present with DI, right? Anything else?
Pituitary
Again, considering.
metastasis usually present with DI, ma'am. Because of the
Sorry?
diets. Ma'am, pituitary metastasis usually present with DI, ma'am.
Right, again, but in the absence of anything else, would you want to consider pituitary metastasis in a, say, a young patient?
No.
Any other differential?
Any craniopharyngioma?
Correct. Craniopharyngioma, right? Craniopharyngioma is a good differential because a patient presenting in the second decade, early third decade, with features of pituitary compression and DI, then you would think of craniopharyngium.
Yes.
Although in this case there is clear acral enlargement, so you're not considering craniopharyngium as a cause. But again, you would not consider DI because it's not a very common associated presentation. Right. So let's move on. So what features of pituitary tumor did this patient have clinically?
He had most of the acromegaloid features are
Right.
there.
Right.
Yes,
So
ma'am.
yeah. So in your provisional, if you were to not have this history of the pituitary surgery,
Yes, ma'am.
right? So you would still say it is acromegaloid facies, provisional being acromegaly. Other differentials can be other features of acromegaloid, like
Yes.
pachydermal periostesis or all the other things that you just said.
Yes.
Uncontrolled hypothyroidism. Although in each of these you will have other features of that syndrome. You will uncontrolled hypothyroidism, you will have features of hypothyroidism. Diabetes, you will have features of diabetes. Okay. So moving on to okay, you showed us a slide on family history.
Yes, ma'am.
Can you go back to the slide? Yeah. So what is the importance of family history in this patient?
So, pituitary tumors can be a familial association has been they can be familially associated, ma'am. So, MEN1 syndrome, MEN4, and familial isolated pituitary adenomas can be associated with can have family histories. So, in these patients, other family members can also have these syndromes. So, family history is important in these cases because he's an young patient. So, family history was important.
So basically, your syndromic causes can have a familial association.
Yes.
One thing. Second, again, in relation to this case, pachydermal periostesis can have a family history. So again, that's an important family history is important in that sense as well. Another point that I wanted to make was this. Yeah. So because we are considering and talking about syndromic association, what other point in history would you becomes important? When you're talking about syndromic association, the idea is that the onset is early. Right. So what other point in history, let's ask Dr. Painivel. What other point in history is important, which I'm not sure if he has mentioned.
Young age of onset, ma'am, less than 30 years, and positive
Correct.
family
Onset is
history.
the patient has presented here at 23 years, which means that
23 years, and
the tumor
and
has been
aggressive
around for
clinical
25
course.
years.
Invasive pituitary tumor, aggressive clinical course,
What I'm
not
asking is,
responding to medical management.
no, what I'm asking is, what other point in history would you want to ask when you're considering an early onset of acromegaly?
Ma'am, other pituitary and other endocrine hormone abnormality like hyperparathyroidism,
Agreed.
pancreatic,
Or syndromic association. Agreed.
MEN1 syndrome, and
Agreed. So what I'm trying to bring out is the point on height. Tall stature is what I'm trying to bring out. So did this patient have tall stature in history?
No history of any tall stature.
What does that tell you?
If there is
Acromegaly.
Yeah, so this patient did not have gigantism from history. So what does that tell you?
So it was the onset was after the puberty, after the
Correct.
closure
So
of
it's
the
post-pubertal. So basically,
post-puberty.
it's a post-pubertal kind of. So an earlier onset or onset before in the early puberty or much before that will result in a tall final stature, right? So whenever you have a young patient with acromegaly, that history is again important. History of stature is important, right? What else do you have? Okay, so go back to your treatment history. So this patient came to us and underwent a transsphenoidal surgery for a pituitary tumor. So this gives you a diagnosis. After that, there's not much discussion. Right. So after the pituitary tumor, he was started on replacement, and then he came to us with persistent enlargement of hands and feet. So what would you think of? What would you think of in case of persistent symptoms?
If patient has persistent symptoms, ma'am, it could be residual tumor, which is there, which is causing the symptoms.
So what are the clinical pointers to persistence, tumor persistence in a patient with acromegaly?
So absence of any soft tissue enlargement symptoms. There is no regression of the soft tissue enlargement. There is
Immediate
increased immediate post-op.
Okay.
And there is persistent oily skin, persistent sweating, and also persistent arthralgias.
Uncontrolled diabetes mellitus, if there is persistent uncontrolled hypertension, ma'am, uncontrolled diabetes mellitus, it continues to be resistant post-surgery.
Correct. So again, immediately when a patient undergoes a surgery for an acromegaly, surgery aimed at curative resection, what is the earliest post-operative finding that you will expect?
One
The
is
earliest thing to happen.
One is polyuria, ma'am, immediately, and also soft tissue swellings are subsided immediately after the surgery due
So
to
let
increase
someone
in
answer
the.
that part on Paul. That's very important. Rebecca, tell
Yes,
us.
ma'am.
So a patient with growth hormone acromegaly undergoes surgery, and then you are called because the patient has polyuria in the post-op period. What
Yes,
are all the
ma'am.
things you think of?
Ma'am, so with acromegaly, we do expect patients who go into remission to have polyuria because of the increased glycosaminoglycan excretion that happens in the urine. So
Right.
polyuria is an expected finding. However, depending on how much of resection was done and what was the aggressiveness of the treating surgeon as well, post-op DI, which could be transient or permanent, will also always be in the background. And usually we would assess this based on a urine osmolarity and serum sodium and then take it further.
Any other causes for a post-op polyuria? One is you said GH removing tumor load itself will result in water loss. Second is you said DI. Any other differential?
Excessive intraoperative fluid administration.
Correct. That's a good differential. Intraoperative fluid. Sometimes what happens is when you aggressively hydrate the patient intraop, or the patient receives fluid loads intraop, so the patient tends to pour it out post-op. So that's intraop fluid excess. That's another differential for post-op polyuria. So the idea is that not all post-op polyuria is DI. Especially in acromegaly, it is to be expected. All right. So, okay. So the earliest to happen is polyuria and the soft tissue improvement in soft tissue signs. So again, as a corollary to this, Jagpati, tell us, what are the findings which are not expected to resolve when a patient undergoes a successful resection?
So the bony deformities like kyphoscoliosis, or if there is the jaw enlargement, these symptoms doesn't improve, ma'am. The osteoarthritis part also may not improve in these patients.
Right.
Yes, and also
Arani is trying to answer something. Yeah.
Ma'am, I want to quickly make it as it could be irreversible manifestations.
Hypertension,
Right, as
valvulopathy,
kyphoscoliosis, but hypertension, valvulopathy, and central sleep apnea, they may not improve. Is another thing which has been mentioned.
What about let's talk about mortality risk. So what exactly is the mortality increased in acromegaly or not?
Yes.
Untreated. Let's talk about untreated acromegaly.
untreated acromegaly mortality risk is increased, ma'am, compared to the normal population.
What
increased cardiovascular risk and also due to increase.
From where the increased mortality is predominantly contributed by what? What causes the increased mortality?
Cardiovascular manifestations.
Cardiovascular manifestation causes increased mortality. So, to what extent in a successfully treated successfully treated acromegaly does this mortality resolve? Does it normalize to general population or still remains elevated?
Still remains elevated.
Still remains elevated.
Right. So, because like you said, much of the remodeling changes does not completely go back. So, some elevated risk still remains. Okay. So, what about acromegaly and malignancy risk? Is that elevated? What about?
Acromegaly risk is the malignancy risk is significantly elevated in acromegaly, mainly because of the downstream effects of the IGF-1, which is increased. And the most common malignancy that is associated with acromegaly, ma'am, is thyroid malignancies, which papillary thyroid carcinoma is the most common, with an odds ratio of almost 7.5. Whereas the second most common malignancy would be a colonic carcinoma, which with odds ratio of 2 to 4.
Right. So, is the mortality increased because of the there are two things. One, the odds ratio that you're talking about is probably about the incidence of those malignancies. What about the mortality because of those malignancies? Is that increased?
That is also increased compared to the general population. If we take those with acromegaly, have an increased mortality rate of compared to those with colon cancer in the general population as well, ma'am.
So I think there is a recent change in that kind of evidence, because the later evidence is, if you look at the previous guidelines for colon cancer screening, there would be a baseline. You will have to do a colonoscopy followed by more frequent colonoscopy when it comes to follow-up. But the recent update says that in addition to a baseline colonoscopy, the follow-up should be as per general population. Right.
Yes.
So because newer evidence has come to show that the mortality risk is not increased, although the incidence definitely is more, especially once treated. So if it's uncontrolled, untreated, then yes. But if it is well treated, eventually the risk normalizes, the mortality risk normalizes to general population. So it is a cardiovascular risk which still may persistently remain elevated. Let's move on.
Regarding colonic carcinoma, ma'am, it's the polyp which is increased, ma'am. Incidence of polyp is increased, but
Yes.
As compared to the general population, but the incidence of carcinoma is not increased as compared to general population, ma'am.
Yes.
The increase of, but the mortality due to colonic carcinoma is increased
Is
in
increased. Mortality due to colonic carcinoma is increased,
Yes,
but
ma'am.
yes, colonic hyperplasia is more. Right?
Yes, ma'am.
Or the hyperplastic polyps, which are more common. Okay, let's move on. Jagpati, now bring us to the summary slide. Right. So, so what is your provisional now?
So the provisional diagnosis is active acromegaly, secondary to persistent residual pituitary tumor with secondary hypogonadism and secondary hypothyroidism.
Hypothyroidism, right. So when do you say active acromegaly, what are features of active disease in acromegaly?
Active disease, there is a persistence of headache, visual blurring, symptoms of visual impairment, and also symptoms of arthralgia. There is persistence of oily skin and also increased sweating. There is persistence of uncontrolled diabetes and hypertension.
So these are features of active disease.
Active acro.
Okay. So, right, let's move on to physical examination.
Yes, ma'am. General examination. The patient had a frontal and supraorbital ridge prominence. Prognathism was present. Acral enlargement of hands and feet was present. Oily skin was present, and deep voice was present. Skin tags were present, which were more than 3. And acanthosis was present in the patient. There was no acne. There was no bony deformities. There was no angiomas, no lipomas, no cholangiomas. There was no goiter. There was no pallor, icterus, cyanosis, chylomicria, lymphadenopathy, and there was no bilateral pedal edema. This is the images of the patient. Here we can see prominent supraorbital ridges, enlarged nose, and also thick lips, and also here we can see the prominent jaw. Here we can see the enlargement of the hands and also the enlargement of the feet. So the height of the patient, it was 168 centimeters, weight was 75 kgs, BMI was 26.6, and abdominal circumference was 93 centimeters, and hip circumference was 94 centimeters, and neck circumference was 30 centimeters. On stop bang score, this patient had snoring and also male gender. Because of the male gender, there were 2 out of the 8 points.
I'm just going to stop you here. Go back to the physical examination. Next slide. Next slide. Next slide. Yeah. What are the screening tools for OSA?
We can use stop bang score. Stop bang score has 8 components, where we have the S stands for snoring.
That's okay. So,
okay.
In addition to stop bang, are there other screening tools which you can use?
Epworth scoring scale is also there, ma'am, where we can see
Sleepiness score, right?
sleepiness score is another.
Berlin questionnaire.
Sorry.
Ma'am, there's a Berlin questionnaire as well. Epworth
Right.
sleepiness score, Berlin questionnaire, and Stop-Bank questionnaires are the relatively more popular screening questionnaires which can be used for detecting patients at high risk for OSA.
Right. How would you want to confirm when do you suspect on a stop bank? When do you suspect sleep apnea? Jagpati.
If the score is between 3 to greater than 2, we say it is
3 or
3.
4.
3 or
It's
4.
So how do you confirm sleep apnea?
We have to do polysomnography, ma'am. By that we can see the apnea hypapnea index. If it is greater than 10, we can say that the patient is having sleep apnea, obstructive sleep apnea.
These studies have considered even 5 as a cutoff. So even mild sleep apnea, many have taken 5 as a cutoff. Right. Okay. Go back to one slide previous. What is the importance of neck circumference in a patient, let's say with obesity? What is the significance of neck circumference? What are the Asian cutoffs? How do you measure neck circumference? Let's ask Harini. How do you measure neck circumference in a patient? Anyone else? Divya, Vishal, anyone?
We need to measure below that thyroid prominence, that cartilage, ma'am, thyroid prominence cartilage.
So what is the cutoff for males and females?
35.5 in males, ma'am, and about 32 centimeters in women. If it is above that,
43 centimeter in men.
for obesity.
Less than 37 in males, madam. Less than 34 in females.
That is the cutoffs, is what I remember. Right. What are the Asian cutoffs for abdominal circumference?
That is 18 females and
90 for males and less than 80 for females.
Females.
Right. Okay. Moving on. Go to your systemic examination. Okay.
Vital data, temperature, patient was febrile, 98.4 degrees Fahrenheit was there, and pulse rate, it was 82 beats per minute, a regular normal rhythm, no radiofemoral delay, and all peripheral pulses were felt. Blood pressure was 120 over 80 millimeters of mercury, right arm supine position, and respiratory rate was 12 breaths per minute. A systemic examination, cardiovascular systemic examination, S1 and S2 were normal, no murmurs were heard. Respiratory system examination, bilateral normal vascular breath sounds were heard. There were no added sounds. For abdomen, there was no organomegaly. On CNS examination, visual acuity was 6/6 in both eyes. Visual fields were normal on confrontation in the both eyes. Fundus was normal in both eyes, and also disc margins were distinct in both eyes. Cranial nerve examination was normal in this patient.
Fundus examination in a patient with acromegaly?
Ma'am?
What would you expect on fundus examination in a patient with acromegaly?
There can be temporal pallor. Early signs of optic nerve compression would be optic chiasmal compression would be temporal pallor can be seen in these patients, or in late stages there can be optic atrophy also can be seen.
Okay. Anything else?
And also if there
Diabetes
is
and
any
hypertensive retinopathy.
Yeah, diabetes and hypertensive retinopathy changes you can be seen.
You can also see glaucomatous changes, ma'am, because the hypertrophy of the tissues can block the aqueous canal of Schlemm, and so that can lead
You
to
have
an
a
open angle.
really large tumor which is causing increased ICT. You can see that as well. Right. Again, you said per abdomen no organomegaly. What organomegaly would you expect?
Hepatosplenomegaly can be seen in cases of acromegaly, ma'am, due to generalized enlargement of all the organs in acromegaly patients.
And
also cardiomegaly can be seen in these patients.
Yeah, about still persisting with hepatosplenomegaly. Any other cause for the hepatomegaly?
If because of these patients has obesity also associated with this, there can be fatty liver also in these patients.
So hepatic steatosis can also cause hepatitis. Right?
Yes.
Okay. again, you said something about cardiomegaly. So if the patient presents with OSA, cardiomegaly, right heart failure, again, you can call congestive hepatomegaly, which can cause hepatic enlargement. So these are clinical questions which you can expect in. Okay, moving on.
The cranial nerves were normal. Motor system examination, bulk, power, and tone were normal in this patient. Sensory system examination was normal. On endocrine examination, his pubic hair was P5, axillary hair was present, stretched penile length was 10 centimeters, and bilateral testes were 20 cc, and there was no gynecomastia. So, summary. A 23-year-old male patient with features of acromegaly, with no history of syndromic association, with past pituitary surgery, with persistent symptoms and signs of active acromegaly, with no signs of vision involvement, with features of hypogonadism and hypothyroidism on thyroxine replacement, and signs of insulin resistance.
What are features of hypogonadism in this patient?
This patient had mainly he had symptoms of hypogonadism.
Right.
He had decreased in the early morning erections. He has a decreased sexual desire, and he had a lower libido.
Right. Yes. What are causes of erectile dysfunction? If the patient presents with erectile dysfunction,
yes.
What are the various causes of erectile dysfunction in a patient with acromegaly?
Acromegaly can cause erectile dysfunction. First, it can be due to a tumor. The adenoma can compress upon the surrounding FSH and LH cells and cause compression of those and decrease the FSH and LH and cause central hypogonadism leading to erectile dysfunction. That is one mechanism. There can be increase in prolactin levels. This increase in prolactin levels can cause hypogonadism in these patients. And also, if there is any pituitary apoplexy due to macroadenomas, then it can also cause post-apoplexy hypogonadism can be seen in those patients.
Yeah. Any other reason for erectile?
GH itself can directly suppress the GnRH secretion from the hypothalamus, and also because of the associated diabetes, secondary diabetes that they can have erectile dysfunction, and more commonly they have patients with acromegaly overall have increased rates of depression and psychological factors which can also lead to the erectile dysfunction.
Low self-esteem.
Various ways in which secondary hypogonadism can happen. Either hypothalamic, either central, post-apoplexy, hyperprolactinemia. In addition to that, diabetes itself can cause, or psychogenic ED. So all of this can happen. Right. So, okay. So this is what we're talking about, a 23-year-old male with acromegaly and persistent disease. Right. Chalo, let's move on.
The provisional diagnosis was active acromegaly secondary to pituitary macroadenoma with likely persistent residual pituitary tumor with overweight and secondary hypogonadism and secondary hypothyroidism on thyroxine replacement and features of insulin resistance.
Right. So it's already 8:40. So let's move on to investigations.
Yes, ma'am. Routine investigations were normal, ma'am. FPS and HbA1c were in the pre-diabetic range. Then ECG, 2D echo, and colonoscopy were normal, and sleep studies could not be. Patient was not affordable for that. Pre-op imaging was done. MRI, contrast enhanced MRI was done, in which there was a
just one sec. Let's briefly talk about what are the initial biochemical investigations that you would do in a patient with acromegaly.
So we do the routine blood investigations, ma'am. Along with that, to establish the diagnosis of
that slide on biochemical investigations.
Ma'am?
Just put that slide on biochemical investigations.
Yes, ma'am.
Yeah. Now let's talk about this. Yes. So what baseline investigations are important?
We have to get the hormonal profiles of thyroid function test should be done, ma'am. FSH, LH, and testosterone should be done for seeing hypogonadism. Prolactin should be done to rule out any prolactinoma, and also co-secreting tumors. And cortisol should be done for secondary adrenal insufficiency, and IGF-1 should be done to establish the diagnosis, to screen for the diagnosis of acromegaly.
So suppose this patient's prolactin is 90.
Yes, ma'am.
nanogram per ml. How would you interpret that value?
So, yes, ma'am. This prolactin, if it is 90, we have to first see if it is normal or dilution to rule out the hook effect, ma'am. So we have to get it in a dilution, 1 in 100 dilution, so to rule out any hook effect. If we get in 1 in 100 dilution and it is then also 92, then we have to suspect stalk compression causing hyperprolactinemia. That could be one cause, because it is only mild hyperprolactinemia, which is less than 100. And also it could also be a eosinophilic stem cell tumor or a mammosomatotroph tumor, where there can be co-secretion of prolactin. But in those cases, prolactin levels would be a bit more than this.
Anything else? Assuming that 90 is actually 90 nanogram per ml. You still have to rule out drug-induced hyperprolactinemia, because it's not uncommon for patients to take, because peptic ulcer is common, headache is common, so they could be on multiple other medications as well. So, and similarly, if a patient is on antidepressants, antipsychotics, then that will again cause elevation prolactin. So that's borderline prolactins, you have to rule out drug-induced hyperprolactinemia, right? So what are the confirmatory tests for GH excess?
So if the IGF-1 is normally greater than upper normal limit, ma'am, then we have, if it is very much high with features of acromegaly, we need not go for the growth hormone suppression test, ma'am. If it is very high, we can, if it is minimally elevated, we can go for the growth hormone suppression test. Here we have to we give the glucose load and see there is an acute rise in our blood sugars in this patient, and see for the growth hormone level at 2 hours.
Right. So again, this is a common thing. If a patient is say has uncontrolled diabetes, let someone answer this. Rebecca. So if you find that this patient has say blood sugars in 200s at the baseline, how would you proceed with a post glucose growth hormone test, and how valid would that be? How would you interpret it?
Ideally, it would have to be under better controlled glucose levels. We may not be able to assess it accurately because the glucose already, the level is high, so we won't be able, the suppression will not be appropriate.
How does uncontrolled diabetes confound, what does it do to the IGF-1 levels, and what does it do to the GH levels?
GH levels will be elevated, but IGF-1 would be low.
Right. Second thing is, see, when you're looking at GH suppression, what you're looking at is the rate of rise of blood glucose. Okay, so it would be ideal to actually control the blood glucose and do the test, but if not, if you're getting in the setting of a high IGF-1, if you're not able to really control the blood sugars, it's still possible that you document a rise in RBS, and then you can interpret it during, so long as so the idea is that you're looking at the rise in blood glucose during the OGTT. That is what causes the GH to get suppressed, rather than the absolute value of the elevated blood glucose, because it confounds more with the IGF-1 rather than the GH. Okay. So, okay, moving on. What did we get at the pre-op imaging?
Pre-op imaging, there was a 3 into 3 into 3.8 centimeter mass, ma'am, in supracellular and supracellular region, with which it was abutting bilateral distal optic nerves, with a NOS score of right NOS 3 and left NOS 2.
So, okay, we have put here a representative image because for some reason the patient did not have the pre-op image with him at the point of presentation, so we couldn't get you that image. But so, Divya, tell us what in a pre-op imaging what are the points that you look at in a pre-op imaging, which will define your planning of surgery or management? Or even
yes, ma'am. If T2 hyperintensity is there, that corresponds to the sparse granularity in the histology, which is actually poor prognosis, like it won't respond to medical therapy. Apart from that, we can see the extent of the tumor, how they can resect the tumor, whether it is compressing and crossing this cavernous sinus. So we can decide the extent of tumor and the T2 hyperintensity for responsiveness.
Right. Anything else that you would like what is Hardy and NOSP grading and how will it affect your management planning?
So this NOSP,
NOSP 4.
so it like how extent we can remove, whether we can go for complete resection or only debulking like of the tumor, we can decide based on the NOSP.
Right. So if you have a NOSP of 3 or 4, you're not expecting a complete surgical remission. So you know beforehand that this is NOSP 3 or this is NOSP 4, the patient is going to have persistent disease. So you might have to plan something after as well. Right?
Yes, ma'am.
Okay, let's move on. So this is what we found. We found a macroadenoma and the patient underwent surgery. Yeah, proceed.
Patient underwent a transvenous surgery on 30th of April and developed transient diabetes insipidus in the post-operative period, and patient developed secondary hypothyroidism and started on tablet thyroxine 50 micrograms per day. And on post-op day 1, GH was 6.8 nanograms per deciliter.
So what does this tell you post-op day 1 GH about possibility of remission?
Still elevated.
It is still elevated, ma'am.
Residual disease. It is indicative of probably residual disease.
And here, in fact, in this case, even before op, you know that for an OSP3 is going to be difficult, right, to take the entire tumor out. Yeah, proceed.
Post-op evaluation at 3 months, hormonal evaluation. Here we can see that the patient was in secondary hypothyroidism. He was replaced with free thyroxine, so his free T4 was in the normal range. He had low testosterone levels and a normal FST and LH representing secondary hypogonadism. He had normal cortisol axis and IGF-1 was still persistently elevated at 751.
Right. So this tells you what?
This tells us that the patient is having persistent residual disease now.
Right.
Yes.
So if you find that the post-op patient has clinically improved and your, let's say, post-op day 1 GH is less than 1 and you do a 3-month IGF-1 and you find that that is, this cutoff is 252. You find that it is 300 or 290 something. What would be a next plan of action?
So if a patient doesn't have any symptoms, we can just wait and watch, ma'am. If patient has persistent symptoms along with a bit mildly elevated IGF-1, then we have to take it as active disease and we have to go ahead with the treatment, ma'am.
So how long? So basically the idea is when does IGF-1 normalize? What time does it take? What is the recommendation? When do you check IGF-1 post-op?
3 months, ma'am. At 3 months, we have to check it.
Decline to the normal range.
6 weeks to 3 months.
6 weeks to 3.
You could do at 6 weeks if you find it is borderline elevated. Again, repeat at 3 months. In a small percentage, it actually goes up to, if you find that patient is clinically otherwise asymptomatic, just a mild elevation of IGF-1, then you could actually consider repeating the IGF-1 at 3 months or 6 months.
After 3 months.
Right. And if the patient has no signs of active disease. Okay, so here we can see that the patient is having deficiencies of 2 axes. So you would want to replace both of them. So what do you want to do about the persistent disease?
So we have to go ahead with the MRI to see how much residual is present, and depending upon that we can decide upon the management plan. So we went ahead with the imaging. So here this is a post-op 3 months image of this patient. Here we can see there is a residual tumor here and also at this point on the right side and on the left side. There was minimal residual.
The opinion of Painivel. Painivel, tell us what do you think we should do for this patient at this point in time? This is
either
yeah.
2 options are there. First one is we'll start with medical management, or we give radiotherapy and superimpose with medical management. So 2 options are available. So we can either choose. Depends on the situation.
Right. So if you want to critically assess the 2 options, what would you? how would you do it? What are the factors in practical sense? What are the patient factors which will favor you giving continued medical therapy over choosing to go for RT?
This is he
Think
is a
about
young
surgery as an
patient.
option. Does anyone of you think surgery is an option? Anyone?
Patient also there is intracellular, a bit of tumor in the intracellular, ma'am. So
Correct.
we
There is
can
a
go
bit of
ahead with.
intracellular tumor, but the problem is we're not going to give him remission, right? There is a lot of tumor around the carotids, so it's going to be difficult. You might end up taking some part of the tumor in the intracellular region, but again, it's difficult that the patient is going to have remission. So when you have a predominantly residual around the cavernous sinus, it's with less of intracellular component. RT or medical therapy is a better option instead of subjecting the patient again to a surgery. What do you guys think, right?
Yes, ma'am.
Yeah.
Yes,
So
ma'am.
correct. So let's see what we did.
The final diagnosis was active acromegaly secondary to pituitary macroadenoma with persistent residual pituitary tumor with overweight and secondary hypogonadism and hypothyroidism and features of insulin resistance. So we went ahead with a management plan. Here, resurgery was not recommended as cure is challenging in this patient. There was no compressive symptoms and there was NOSP 2 on one side.
It was NOSP 3.
Yes, ma'am. One side NOSP 2 and one side NOSP 3. And also the radiotherapy is recommended in this patient because there was no compressive symptoms and the NOSP was 3. And also medical management was planned for. We can plan for medical management until the patient under the effects of radiotherapy take hold.
Right. So suppose you had a residual which is closer to which is in this, you have a tumor persisting in the supracellular lesion that is closer to the optic chiasm. Then what would your management change?
Surgical debulking, ma'am, would be preferred
Yes.
at that point of time.
Yes, in that sense, radiotherapy is a bad option. So radiotherapy, if a tumor is the ideal, in this case, it's ideal because the tumor is away from the optic chiasm and it's closer to the cavernous sinus. So this makes this patient ideal for radiotherapy. Okay, and medical management, of course, if the patient is able to afford medical management for long, you could consider the medical management. So, Nitin sir, do we have time for more discussion, or shall we stop here?
Yeah, I think in the interest of time, we'll stop.
Right.
Maybe one last question if you have, or one last point if you want to.
So we can discuss at length about the various. In fact, we have not touched much on the management for lack of time. So on long-term follow-up, finally, what are the other things you will, in addition to the disease control for acromegaly, what are the other things you will follow in this patient?
We have to look for other complications.
What other things you'll follow?
The obstructive sleep apnea, the colonic, we have to screen for colonic malignancies continuously. And also the diabetes part and the hypertension part should be taken care of.
So the patient has, one is the metabolic part, right?
Yes.
Metabolic control. Then cardiovascular control, because we're not giving him a disease remission completely. So what will be your targets for acromegaly management? What would you monitor and keep it in target?
IGF-1 should be in the normal range.
Mid-normal is the target. Normal range is the target. Right? Metabolic control and malignancy screening. So like I said, the recent pituitary update says initial colonic colonoscopy followed by guidelines as per the general population, which is I think 10 years.
10 years. 10 years.
Plus the cardiovascular risk, disease management of dyslipidemia, management of hypertension, diabetes, all this. And of course, control of pituitary axis, right? Other pituitary axis. Right, sir. So I think with this we'll end the discussion because predominantly for lack of time. So
Thank you so much, Dr. Kalyani, and thank you, Dr. Jagpati, for that very clear presentation. Thank you all the panelists for answering all the questions. Dr. Jagpati, could you stop sharing your screen?
Yes.
So we shall now move on to the quiz part of the case capsule, where we are going to have the 10 short questions. Actually, I prepared some of the questions right now while listening to the discussion. So definitely, I would say this is something, if you've really listened through the presentation, you should be able to get good points. So are you able to see my screen? The case capsule?
Yes, sir. Yes, sir.
Sure. Great. So I think all of you are now very well versed with this particular quiz format, which is a simple Mentimeter quiz. You'll know how to join in the next slide. And there are 10 short questions, all MCQs, single best response. Fastest fingers first, so you get more points if you answer correct and you answer fast. Maximum 1,000 points per question, no negative marking. So I think all of you are well versed, so I'll just get started. So this is the code to join the quiz. So I request all of you to join. I'll give 1 minute time. In the next slide, when you get a chance to enter your name, I would request you to enter your correct name so that we can easily identify you once you win the prize. I'd also like to acknowledge Professor Nisha Bhavani, who's contributed to the questions of the quiz. Madam could not join today, but has definitely contributed to the quiz. So I already see 58 thumbs up. So usually we have about 70 people who join. So I think with this, let's get going. We have about 75 people who joined. All right, so let's start with the first question. This question is about oral octreotide, and you have to find out the accept question. All right, so a large majority of you are aware that it is not absorbed by a transcellular route. Let's move on to the next question. Wonderful, Dr. Prasiddha, you're leading, but others are not to be disappointed. You don't know how this quiz turns out. Let's look at the second question. Today we have 83 people who joined. Markers of GH action include all except. It's time bound. You have to answer within 15 seconds. All right, so FGF21 is the correct answer. Let's see how you performed. Most of the top 10 have got the answer right. Dr. Prasiddha is still leading. Let's look at the next question. Only drug which is shown to reduce vertebral fractures. Not many people have got this right. So the answer is pasireotide, but I'm sure this will change the score significantly. Right, every question matters. So Dr. Ravisha is now moved up. Others not to be disappointed. I'm sure you can see your place on your screen. Only the top 10 are shown here. But every question can make a big difference. Let's move on to the fourth question. Right, again, not many have got this right. There was an except in the question. But many in the top 10 have got it right. So Dr. Ravisha is still leading. Let's look at the next question. Genetic markers of poor response to SRL. If you don't know, you can guess. No negative marking. A great majority have got this correct. Congratulations, Dr. Ravisha, still leading by 700 points. One question can again make the difference. We are halfway through, another 5 questions to go. Simple question. Talking of disease persistence, except. Great, simple question. Direct questions from Williams. Younger patient is the answer, not older patient. Okay. Dr. Ravisha is still leading. 4 more questions to go. Side effects of octreotide, all except. Another simple question. More than constipation, it is diarrhea. Okay, change in the scores again. Dr. Archana is now leading. As I said before, every question is important, can change the score significantly. Last three questions. Another simple one, conventional radiotherapy for acromegaly. All except. Yes, it's not so common to have pituitary apoplexy. We don't use conventional RT so much now, but before it was only 2%, not 7%. Right, scores are changing again. Archana is still leading. Very close fight between Archana and Divishri. Let's see how you do in the last two questions of the quiz. Cash price is 10,000 rupees. Very simple question, I would say. There's increased energy expenditure, not decreased. So I think this will change the scores again quite a lot. Okay, Dr. Archana has maintained her winning stride. Dr. Ravisha has come up second. Very close fight, 5 points only. The last question will decide who will take the cash prize for today. After you win, please message me directly that you're the winner from which institute. We'll contact you regarding how to transfer the prize. So wish you all the best. Last question. This was discussed. Okay. Let's look at the answer. Yeah, I think in the last question there should have been an except, which is not there, but it did not change the scores of the winner. So I think Archana would be still the winner. So congratulations, Dr. Archana. I request you to please message me your details and which college you're from. We'll contact you for the prize. Thank you everyone for joining today, and we will come back with the next edition of the ESI case capsule again on the last Wednesday of every month. And thank you again for joining, and thank you, Dr. Kalyani, and the entire team of DM students who joined today as panelists.